Hello, my name is Jacob Thyssen. My pleasure to discuss briefly environmental exposures and allergens in atopic dermatitis. And here are my conflict of interest. So let's start by looking at the 1980 Hannifin and Reichert criteria of atopic dermatitis. Now, atopic dermatitis really is a syndrome, and it can be used as an umbrella term to capture a set of symptoms and clinical signs that are different between patients. But I think the Hannifin and Reichert criteria to a high degree capture what's important for this syndrome. And among these, there are all the environmental exposures. So for example, it's highlighted that patients have elevated serum IgE, they have increased immediate type skin test reactivity, emphasizing how allergen exposure can lead to symptoms in this group of patients. And also you can see that there is a tendency towards cutaneous infections against Staphylococcus aureus and herpes simplex. And then also itch is highlighted, intolerance to wool, and then food intolerance and how the course may vary with environmental exposure. So all in all, I think it's really inherent in this set of syndrome that environmental exposures affect atopic dermatitis. Now, in this recent review article by Stefanovic and colleagues, I think the figures are very nice for a talk like this one. First of all, it can be seen that an individual with a genetic susceptibility may develop atopic dermatitis due to environmental exposures, but it also has to do with the doses of exposure and the timing of exposure. And then it's important to highlight that some factors are good for the skin barrier, whereas others are bad for the skin barrier. So let's start by looking at one of the factors that are unavoidable for humans, that is seasonal changes and climate. Because what we see is that many great urban areas in North America, Europe, and Asia are located in areas where winters are very cold. This leads to a drop in ambient humidity, and what happens is also that we heat our homes, which lead to a further decrease in ambient humidity. At the same time, there is increased air pollution with particulate matter, and also there is a scarcity of UVB photons that reaches the skin of these humans who tend to stay inside and miss the few sunshine rays that will get below the fog and the air pollution. So the effect of a dry environment was studied recently by our group, and what we did was we collected tissue from the same adults in the summer and in the winter from cheek skin and dorsal hand skin, which are the exposed sites of the skin. What we saw was that these nano-sized protrusion on corneocytes were much higher in numbers in the winter, and these are associated with dry skin, and they are associated with any deficiency in the filacrine axis, again indicating how dry environment is bad for the skin area. We've also tried to look at the effect of a cold climate. So here on the left there's a figure showing atopic dermatitis prevalence of 60,000 babies that were followed and examined for atopic dermatitis in the first 18 months of life. And you can see that the risk of developing AD was highest for those who were born in November and fall and winter months generally. On the right you see the correlation between the number of topical prescriptions using topical corticosteroids and topical calcineurin inhibitors, and then by drop in temperature in Denmark. And we see that the colder it gets, the more consumption of these topicals are done. We could also see in the same study that there was a higher number of visits to the ER and to ambulatory working dermatologists during the winter. Some time ago, me and some colleagues, we reviewed the positive effects of UVB photons on the skin barrier. And basically, they, in the right doses, they improve all aspects of the skin barrier. And therefore, I think it's interesting that we now try to prevent UVB exposure in infants and young children to prevent premature skin aging and skin cancer. And while that is very important, we also should be aware that there are positive effects of UVB exposure. So In a study that was conducted in Australia some years ago, the intention was to study the effects of vitamin D oral supplementation. But at the same time, these babies also had a measurement on their arms that measured UVB exposure. After this randomized controlled trial was over, the authors concluded that oral vitamin D supplementation did not alter the risk of eczema, whereas the children that had been exposed to the highest amounts of UVB had almost half the risk of developing eczema in this prospective trial. So the positive effects of UVB should not be underestimated. And it's really interesting to see that back in 1930s in New York City, these iron cages were very popular because it was believed that children should be outside and benefit from sunshine. Looking at air pollution, I think there's an increasing number of studies showing the same results, that the more you're exposed to particulate matter, the worse it is for your skin barrier, and the higher the risk of developing eczema and also atopic dermatitis. I think one of the most convincing studies was a recent one that came out showing that particulate matter, 2.5, would increase TNF-alpha release in the skin, and this would lead to increased water loss and downregulation of filaggrin. And what was very interesting in this study was that they measured filaggrin degradation products in the same individuals when they lived in Denver, where there is low degree of air pollution, and then also in Seoul, where there's much more air pollution. And they could see really that the barrier indicated here by low natural moisturizing factor levels, it was much worse in Seoul compared to Denver, indicating the negative effects of air pollution. Another unavoidable factor for human activity is bathing water. And a number of studies, including one from my own country and also from the UK, show in a very convincing way that the higher the calcium content and thereby the domestic hardness of our water supply is, the higher the risk of eczema. And this seems to be most pronounced in filaggrin mutation carriers, as indicated by the data from Carsten Floor's group, and also partly replicated by data from my own group in Denmark. So we really don't understand the mechanism behind the negative effects of hot water on the skin barrier. So it's known that if you have hot water, it's difficult for soap to foam, and therefore you may tend to use more. Hot water also has a higher pH level, and therefore in theory you may activate some enzymes that will lead to barrier destruction. We have tried to look at the effects of soft water versus hot water on the skin, and we could see that hot water led to higher IL-4 cytokine levels compared to softer water. And Carsten Floor's group have looked at SLS, that is an irritant deposition on the skin, and how easy it was to remove using either hot or soft water, and showed that hot water was not as effective in removing SLS as soft water. With regards to the risk of peanut allergy and allergen sensitization, we have now very convincing evidence showing that AD severity and filaggrin mutations both worsens the skin barrier, are strongly associated with peanut sensitization, indicating that a leaky barrier will lead to increased allergen exposure and sensitization. Some nice studies have been done by Thomas Werfel's group in Hanover, Germany, and they show that atopic dermatitis patients who are, for example, grass allergic will react with worsening of AD when exposed to grass pollen on their skin, and also that birch allergic atopic dermatitis individuals will develop some immediate and also delayed worsening of their eczema if they have an intake of birch pollen-related allergic foods. Pet ownership is very popular during COVID-19 times, but there is no association really between cat exposure and risk of pediatric atopic dermatitis, whereas there seem to be some protective aspects of having a dog on the risk of developing atopic dermatitis. It was hoped some years ago that use of emollients in healthy infants, and particularly those at risk of developing atopic dermatitis, would prevent or reduce the risk of onset of AD. But now we know that this is not possible. At least it has been unsuccessful in the trials that have been conducted. And there's even a signal that indicates that there's an increased risk of food allergy in those that use emollients, perhaps due to increased penetration of allergens in human skin. But also, it could be that emollient use will further skew the type 2 inflammatory activity and thereby increase the risk of food allergy. So we can't use that strategy as it is now. And with that, I want to thank you for your attention.